Netra SS with her presentation titled PPH Panic, Stopping the Floodgates. Dr. Netra SS is a highly experienced anesthesiologist with 29 years of dedicated service in the field. She currently serves as a professor and head of the department at Bangalore Medical College and Research Institute. She has held several key positions, including Secretary of ISA Bangalore Metro Branch since October 2022, Secretary of ISACON Karnataka 2024. Her work reflects a strong commitment to excellence in patient care, teaching, and academic leadership in the field of anesthesiology. Dr. Netra will help us stay calm and in control during the postpartum hemorrhage. Over to you, ma'am.
Good afternoon, everyone. I think after delicious lunch, everybody are feeling sleepy. I think I won't bore you. Today I'll be talking about PPH, postpartum hemorrhage. Greetings from BMCRI. So when you get a case of PPH in the OT, not only the obstetrician, with her team, they'll be really tensed up. So we should act like a captain in the ship and manage the cases. Briefly, I'll tell about a case which we had done in our hospital, that is Vani Vilas Hospital, which is a tertiary care center. Daily we'll be doing around 26 to 29 cesarean delivery. So there was a parturient. She came with a placenta previa of grade 3. So she was scheduled for the elective cesarean section. Intraoperative events were uneventful. Active management of third stage of labor was managed by giving oxytocin. Then later, uterus was contracted and she was assessed for the blood loss. She had a blood loss of 900 ml. That was usual. And there was no PV bleeding when the abdomen was closed. So during reversal, again she was examined per vaginally. She had a bout of 500 ml blood loss. So we gave injection methergine 0.2 milligram intramuscularly. After 10 minutes, again she was examined per vaginally and she had bleeding again. So the more the blood parturient loses, she loses her life. So I'll be discussing about the stopping the floodgates in a postpartum hemorrhage parturients. So I'll be discussing with respect to these headings. What is the definition? Previously there was no definition. There was traditionally it was defined as a blood loss from the genital tract about 500 ml after the vaginal delivery, or a blood loss from the genital tract of more than 1000 ml after the cesarean section. The WHO in the 2012 defined it as blood loss of more than 500 ml or more within the 24 hours after birth. The American American College of Obstetrics and Gynecology defined in the year 2017, it is a cumulative blood loss more than or equal to 1000 ml regardless of the route of the delivery. The Royal College of Obstetricians and Gynecology in the year 2017, they defined it as minor blood loss of less than 1000 ml and more, major blood loss of more than 1000 ml. So PPH is again classified into primary PPH and secondary PPH. Primary PPH, which occurs within the first 24 hours after delivery, and the secondary PPH occurs from the 24 hours up to 26 weeks of postpartum. The major obstetric hemorrhage is defined as blood loss of 2 to 2.5 liters, either antenatal or postnatal. See, the severe PPH, according to WHO, is the more than 1000 ml of blood loss. The estimated blood volume in a parturient at term is around 40 to 50%. So this picture shows the average blood volume in different age groups, and in the women it is 65 ml per kg. So at term, it is 100 ml per kg. This is very important because we can't give the blood by seeing how much she has bled. We have to give the blood according to her blood loss per kg. So in a 70 kg, usually the blood volume will be around 7 liters. When the participant loses up to 15 to 40% blood loss, she will be losing around 1000 to 2800 ml. Whereas in 50 kg, she will be having the blood volume of 5 liters, but if 15% blood loss is there, 750 ml. And don't think that she's not blood and don't think that we should not give blood. We have to give the blood here. So the incidence, the maternal mortality rate according to Pradhan Mantri Surakshit Matritva Abhiyan, it is 93 among 1 lakh live births in the year 2024. In future, I think it will be reduced by 70 in 1 lakh live births. So this picture shows the causes and incidence of the postpartum hemorrhage. The major cause is the atony, and next comes the retained dystocia and retained placenta, trauma or laceration, placenta previa and placenta abruptio, and the remaining is the undefined bleeding causes. Again, in the uterine atony, the severity is 15.7%, and in the retained placenta, it is around 29.3%. So the etiology, you should always remember the 4 T's in the postpartum hemorrhage. The 4 T's are, one is the tone, that is uterine atony. So that will account for 70%. Next is the trauma. The trauma might be in the vulva, vagina, cervix, or there might be uterine rupture also. So next, the other one is the tissue. Tissue is the retained products of conception. And next is the last is the thrombin. There might be coagulation problem with the PPH that will lead to DIC. So this picture shows the common causes of the postpartum hemorrhage. The pathophysiology is normally the uterus receives the blood supply from the anastomotic branch of the ovarian and the uterine artery. This forms a plexus of the arcuate arteries which will wrap around the uterus, and it gives rise to radial and spiral arteries. The spiral arteries increases in number at term, and they are the valvulus arteries, and they are unable to contract. The uterus has to contract for the spiral arteries. So the intravenous blood supply will be around 500 ml per minute. In a non-pregnant woman, the uterus received around 100 to 200 ml per minute of the blood, and that is around 3 to 5% of the cardiac output. Whereas in the term, it receives around 700 to 800 ml per minute, and this encourages the cardiac output. Whenever there is a trigger, so this increase in cardiac output leads to increase in the blood loss. The one more mechanism is there, when a trigger is there, it causes the trigger in the coagulation cascade and causes PPH-induced coagulopathy, that is consumption coagulopathy. In obstetrics, it is consumption coagulopathy, whereas in trauma, it is dilutional coagulopathy. So how do you assess clinically? Clinical assessment is mainly based on the blood loss. If the participant is having 10% blood loss, they will be having mild tachycardia and normal blood pressure, and there will be compensated level of shock. Whenever there is 15% blood loss, the participant will be having tachycardia of more than 100 beats per minute with hypotension, and there is mild shock. When there is more than 30% blood loss, she will be having tachycardia with hypotension and urine output less than 30 ml per minute, and there will be a moderate level of shock. With 40% blood loss, the participant will be having either bradycardia or tachycardia with hypotension, and she will collapse, and the level of shock will be very severe. So we usually have in our hospital maternal mortality audit. So when we attended that, surprisingly, they were doing the blood loss assessment by shock index. What is shock index? It is the ratio of heart rate to systolic blood pressure. And there are variants of shock index, that is modified shock index, which is ratio of heart rate to mean arterial pressure. One more is respiratory adjusted shock index. It is the ratio of heart rate to systolic blood pressure into the respiratory rate by 10. So normally the shock index will be around 0.6 to 0.7. This mainly assessing the blood loss. So usually we depend upon the hemodynamics and give the blood. No, we should not do. We should assess the shock index. See, with a moderate shock, although the shock index is more than 1, and the patient will be having heart rate of 100 and systolic blood pressure of 100 millimeters, we think we need not give the blood. But we have to give blood when the shock index is more than 1. So clinical assessment is mainly based on the blood loss is mainly based on the visual estimation, weighing the mobs, collection devices, and artificial intelligence mobile apps. So visual estimation is not accurate because on one side you might think it is a 5 mobs, on the other side the other person might think there are 7 mobs. So the visual estimation, when the mop is fully spilling, it is 100 ml. When the kidney tray is full, it is 500 ml. The parchment lying on the cot with a bedsheet soaked, it is 1000 ml. And when the bedsheet is soaked and it is spilled over to the floor, it is 2.5 liters. So weighing is, first we need to weigh the wet mop and you have to minus it by the dry mop. That gives the blood loss estimation. Another one is the collection devices. The artificial intelligence mobile mops, it is there in the iPhones and iPad. So there they use the Triton system using feature extraction technology. This is US and FDA approved. The investigation, whenever you see a major hemorrhage, you have to initiate major hemorrhage protocol and send the blood investigation immediately, like hemoglobin, BT-CT, clot, and the prothrombin time and APTT. Why we need to send? Because it helps in assessing the the basic level she had and in treating the case. So if the facilities are there, you can go for viscoelastic assay and thromboelastogram. So what is the target value? The target hemoglobin should be 7 to 9 gram per cent. Platelet count should be more than 50,000. Fibrinogen more than 200 milligram per deciliter. And prothrombin time of less than 1.5. This picture shows the thromboelastogram, so which is very helpful in giving the blood and blood products. This will help in giving what type of exact products to be given, even with like tranexamic acid also it will tell. So as I don't have time to explain this, I won't be going in detail. The management, so multidisciplinary collaboration should be there. We all know that we have seen 3 hours and we are waiting for another 3 hours to come. So what are the 6 hours in the management of postpartum hemorrhage? The 6 hours are one is risk assessment, risk reduction, recognize, react and resuscitate and reevaluate. So what is the risk assessment? So we have to clinically assess the parturient from the antenatal period and see what precipitating factors are there. So this picture shows that stage 0 where there is no bleeding and we had to assess clinically, preoperatively or in the antenatal checkup. So the parturient, if there is no bleeding, she will come to green zone. Next is the parturient who is having more than 500 ml ongoing blood loss. So get a help, act and see what is the cause of bleeding and treat her. So if the parturient is having more than 1000 ml, she'll come to amber color. So treat accordingly. When the more than 1500 ml, it is stage 3, that is red alert. So what is risk reduction? Early detection of the postpartum hemorrhage is the risk reduction. So this we had to follow motive. Motive is you had to give massage, uterine massage, oxytocin, tranexamic acid, IV fluids, and assessing the per vagina for any bleed. And if the postpartum hemorrhage is there, we have to treat accordingly. So risk reduction also consists of active management of 3rd stage of labor. So what is it? It is giving oxytocin intramuscularly 10 units immediately after the delivery of the anterior shoulder of the fetus within 1 minute. And next is cord clamping, controlled cord traction, examining the placenta, observation for signs of any hemorrhage, uterine fundal level, evidence of collapse, any abdominal pain or respiratory difficulty. So post-operatively, we have to shift for ICU and monitor for 4 to 6 hours. So this picture shows we need to monitor the hemodynamics and how much over the blood loss, and we have to stage accordingly. One more method of risk reduction is use of uterotonics. So what are the receptors of the uterus? There are oxytocin receptor, prostaglandin receptor, and alpha-1 receptors. So the drugs acting on the oxytocin receptor are the oxytocin and carbitocin. Carbitocin is a newly drugs and it is more heat stable. So both can be given IV or IM. So, and the dose is the onset of action is 3 to 5 minutes with the oxytocin and immediate with the carbitocin. Duration of action is more longer with the carbitocin. The adverse effects with the oxytocin is it causes increase in heart rate, decrease in systolic blood pressure, and it causes ST depression. So, and it causes vasodilatation. Hence, always while giving intravenously, we should be very cautious and given slowly. Carbitocin, if there is a pre-exposure of the participant with the oxytocin, it causes pre-exposure competitive inhibition. So the next drug is the carbopras, that is prostaglandin F2 alpha. So this IV should not be given, only IM. The dose is 250 microgram and it can be given 8 times maximum, that is up to 2000 microgram. Because it causes bronchospasm, nausea, vomiting, should not be used in the bronchial asthma parturients. One more thing is ergometrin. This also can be given IV and IM. The dose is 0.2 milligram to a maximum of 0.5 milligram. As it increases the heart systolic blood pressure and causes coronary spasm, it should not be used in PIH and in the cardiac parturients. So whenever you give a uterotonics, you should monitor you should enter what time you have given. So one more drug which acts on the fibrinolytic system is the tranexamic acid. It reduces fibrinolysis and stabilizes the fibrin clot, so thereby decreasing the fibrin degradation products. So the dose is you have to give 1 gram over 10 minutes and can be repeated 30 minutes after that. And again after, if bleeding is not stopped, after 8 hours it can be given. So what is the impact of treatment delay in severe bleeding? If you delay by immediate treatment, 30% improvement in the survival. For every 50 minutes delay, it will cause 10% reduction in the survival. After 3 hours, there is no benefit. This is as per Women Crash 2 trial. So this picture shows that the oxytocin, misoprostol, and ergometrin, these 3 drugs can be given as a prophylactic as well as treatment. Carbitocin, only it is given as a prophylactic, and tranexamic acid, it is given only for the treatment. So early recognition of shock, as I told you, we had to use the shock index, and the one more is rule of 30. Rule of 30 is more than blood loss of 30% blood volume, 30% fall in the hematocrit, hemoglobin, and 30 millimeters fall in the blood pressure and increase in the heart rate by 30 beats per minute. But the FIGO recommends use of shock index. So management includes, first you have to react. How? You have to assess the postpartum hemorrhage, immediately take measures. First you need to give fundal massage and use of uterotonic drugs. Additional intervention includes tranexamic acid and use of blood and blood products. The mechanical and surgical management techniques are Bakri balloon for tamponade, and you can use even Stengs-Taken Blackamoor tube, Bailey suture, Zada system, then bilateral uterine artery ligation, internal artery ligation. Nowadays they are using aortic cross clamping and hysterectomy. So whenever there is a major hemorrhage in adults, we need to resuscitate when there is more than 40% of blood loss and more than 4 liters in 24 hours. Initiate the major hemorrhage protocol, get a multidisciplinary collaboration and assess the ABC, secure 2 IV lines, especially with the 16 gauge cannulas or 14 gauge cannula, and send for the blood investigation and ABG if facilities are there. Next is massive transfusion protocol. You have to give dynamic or 24 hours. Dynamic is giving 4 PRBCs in, with ongoing blood loss, or replacing 50% of the total blood volume in 3 to 4 hours. In the 24 hours, either you can give 10 units of RBCs in 24 hours or replacing the total blood volume. So whenever there is no, the blood group is not cross-matched, you can either give the blood group O, or also you can give O negative blood. When the laboratory results are available, if there is falling HB, you need to give PRBCs. So it increases by 1 gram per deciliter. And if the APTT or prothrombin ratio is more than 1.5, you need to give fresh frozen plasma. When the fibrinogen level is less than 2 grams per liter in the obstetrics, you need to give cryoprecipitate. So in a non-pregnant female, the fibrinogen level will be around 230 to 490, whereas in a term, it will be around 370 to 620. So hence, when in the OBG less than 2 gram, you need to supply with the cryoprecipitate. And the next drug newly invented is lyophilized and purified human plasma fibrinogen, but it is very costly. So with the FFP, it increases by 2.5 gram per liter. With the cryoprecipitate, it increases by 15 grams per liter. With fibrinogen concentrate, it increases by 20 gram per liter. So when the platelet is less than 50, you need to replace with platelets, either RDP or SDP. So after giving all this, you need to correct the hypocalcemia by giving calcium carbonate or calcium gluconate. So next is the tranexamic acid. How to prevent coagulopathy? Either by giving the blood and blood products and tranexamic acid. So the re-evaluation or review, we have to review the parturient is by lethal triad. So lethal triad includes whenever there is a massive blood loss, you need to assess for the coagulopathy and give the blood and blood products. When there is hypothermia, use the blankets or warm the parturient, give IV fluids, warm IV fluids. When there is acidosis, you need to give crystalloids more than the colloids. So this picture again shows whatever I told, how to manage a postpartum hemorrhage parturient. And the anesthetic consideration in PPH is, goals is to restore the, monitor the and restore the volume, and you have to target the blood pressure for 55 to 65 millimeters of mercury, and monitoring should be basic monitoring, and consider invasive lines also. For the retained products, you need to give epidural if the parturient is stable, or ketamine with the GA can be given, and with the halogenated inhalational agents. Nowadays, halothane is not used. We can use other agents like isoflurane. So for placenta accreta, you need to give general anesthesia. For uterine inversion, again, halogenated inhalation agents to be given with GA. For the genital trauma, you can give local or by pudendal nerve blocks can be given. So to conclude, assessing the postpartum hemorrhage is the leading cause of maternal morbidity and mortality around the world. So quick clinical assessment and prompt treatment helps in reducing the mortality and morbidity. So these are my references. I thank the organizing team of Karnataka ISA Conference 2025 for giving me this opportunity. I also thank my colleague Dr. Bhaskar who helped me in doing this presentation. Thank you.